လာပါဒီနေ့ဗီဒီယိုလေးမှာကိုရီးယားနိုင်ငံ Maruchi An ထုတ်လုပ်ထားတဲ့ endosonic blue ultrasonic irrigation device အကြောင်းကိုပြောပြပေးချင်ပါတယ်ဒီ endosonic blue ဆိုတာ endo ဘိုင်းမှာတည်တည်ချာချာ research ပြုလုပ်ထားတဲ့ wireless passive ultrasonic irrigation system တစ်ခုဖြစ်ပါတယ် endodontic treatment တစ်ခုရဲ့ primary goal ကတော့ root canal တွေထဲမှာရှိတဲ့ယောဂဖြစ်စေတဲ့ bacteria တွေကိုဖယ်ရှားပေးဖို့နဲ့ peri-apical tissue တွေကို healing ပြန်လည်ရရှိစေဖို့ဖြစ်ပါတယ်ဒါပေမဲ့ရှုပ်ထွေးတဲ့ root canal system တွေကို disinfection လုပ်တဲ့အခါမှာတစ်ခါတရံစိန်ခေါ်မှုတွေရှိတတ်ပြီးတော့ပိုကောင်းတဲ့ strategy တွေလိုအပ်တတ်ပါတယ်အဲ့လို strategy တွေထဲမှာတော့ endosonic blue မှာအသုံးပြုထားတဲ့ passive ultrasonic irrigation ကပိုးဝင်နေတဲ့ root canal တွေကို disinfection လုပ်တဲ့နေရာမှာထိရောက်မှုရှိတဲ့ strategies တွေတဲ့တစ်ခုဖြစ်ပါတယ် root canal ထဲမှာရှိတဲ့ bacteria တွေနဲ့ microbe တွေကို irrigation သေချာလုပ်ဖို့အရေးကြီးဆုံးဖြစ်ပါတယ်ဒါကြောင့်ကောင်းမွန်စွာ irrigation လုပ်ထားတဲ့ root canal ထဲမှာ canal preparation နဲ့ shaping လုပ်လိုအပ်တာဖြစ်ပါတယ်ဒါကြောင့် passive ultrasonic irrigation ကိုအသုံးပြုခြင်းဟာ biofilm တွေကိုဖယ်ရှားပေးပြီးတော့ smear layer တွေကိုရပ်တန့်စေတဲ့အတွက် clean ဖြစ်တဲ့ canal တစ်ခုကိုပေးစွမ်းနိုင်တယ်ပေါ့နော် endosonic blue ရဲ့ tip လေးတွေဆိုလို့ရှိရင် stainless steel နဲ့ polymer tip တွေထက်ပိုပြီး flexible ဖြစ်တဲ့အတွက် curve ဖြစ်နေတဲ့ canal တွေမှာအသုံးပြုရလွယ်ကူစေမှာဖြစ်ပါတယ်ဈေးကွက်ပထမအဆုံးသင်ရောဆက်ပြီးသား premise MDA ဖြစ်တဲ့ endosan MDA premise လေးအကြောင်းပြောပြပေးခြင်းတယ်ပေါ့နော်သူ root perforation repair pap capping root and filling apacification အစရှိတဲ့ endo treatment တွေမှာအသုံးပြုနိုင်တယ် physiological mineral ပါဝင်တာဖြစ်တဲ့အတွက်သွေးထွက်တဲ့ case တွေမှာဆိုလို့ရှိရင်သွေးခဏလေးနဲ့တိတ်စေရပေါ့နော် setting 3 to 5 minutes ပဲကြာတာဖြစ်တဲ့အတွက်သွေးတွေ sliver တွေနဲ့ရောဆက်သွားတာကိုနည်းပါးစေတယ် endosan MDA ရဲ့ရေနဲ့ထိတွေ့လိုက်တာနဲ့ချက်ချင်းမာသွားတာဖြစ်တဲ့အတွက် wash out ဖြစ်တာကိုလည်းကာကွယ်ပေးတယ်ပေါ့နော်ပုံမှန် MDA မှာပါတဲ့ 2 discoloration ဖြစ်စေတဲ့ bismuth oxide ကိုစားထိုးပေးထားတာမို့လို့ရောဆက်အသုံးပြုရတဲ့ MDA type တွေထက် 2 discoloration ဖြစ်နိုင်ခြေပိုပြီးနည်းပါတယ်ပေါ့နော် Dantina tubules လေးတွေကိုစီးလုပ်ပေးနိုင်တဲ့အတွက် hypersensitivity ဖြစ်ခြင်းကိုလည်းကာကွယ်ပေးနိုင်တယ်အသင်ရောဆက်ပြီးသား syringe type ဖြစ်တာကြောင့်အသုံးပြုပြီးတဲ့အခါမှာစီးပိတ်ပြီးသိမ်းဆည်းထားနိုင်ပါတယ်မင်္ဂလာပါကိုရီးယားနိုင်ငံ Maruchi ကနေထုတ်လုပ်ပေးထားတဲ့ endoCMDA Bioceramic စီလာလေးအကြောင်းပြောပြပေးလို့ရပါတော့ဒီ endoCMDA ရဆိုလို့ရှိရင် healing ပိုင်းပုံမအားကောင်းလာစေပြီးတော့နောက်ဆက်တွဲပြဿနာတွေမဖြစ်လာအောင်လူခန္ဓာကိုယ်နဲ့လာရောညှိတွေဖြစ်အောင်ထုတ်လုပ်ထားတာဖြစ်တဲ့အတွက်ကြောင့်မလို့ဒီ biocompatibility ဘိုင်းမှာစိတ်ချရပြီးသား Bioceramic စီလာဖြစ်တယ်ပေါ့နော်သူ့မှာဆိုလို့ရှိရင်စွမ်းအားထက်တဲ့ alkaline pH ပါဝင်တာဖြစ်တဲ့အတွက် bacteria တွေမပေါက်ဖွားနိုင်တဲ့ root canal တစ်ခုဖြစ်အောင်သူကဖန်တီးပေးနိုင်တယ်ပေါ့နော်ဒီ patient ရဲ့သဘာဝသွားရအောင်တွေမပြောင်းသွားအောင်လဲသူကထိမ့်သိမ့်ပေးနိုင်တာဖြစ်တဲ့အတွက်သွားကြမှာရင်းနဲ့ aesthetic ဘိုင်းမှာဆိုလို့ရှိရင်လည်းစိတ်ပူစရာမလိုတော့ဘူးပေါ့နော်ဒီ endoCMDA ရဆိုလို့ရှိရင် solvent အများစုနဲ့လာရောညှိတွေဖြစ်တယ်ပေါ့နော်အဲဒါကြောင့်မလို့အကြောင်းကြောင့် root canal တွေကနေစီလာတွေကိုပြန်ပြီးဖယ်ခြင်းနဲ့ဆိုလို့ရှိရင်အလွယ်တကူဖယ်ရှားနိုင်စေရပေါ့နော်သူ့ရဲ့ setting time ရဆိုလို့ရှိရင်10 to 12 minute ဖြစ်တယ်အဲဒါကြောင့်မလို့ obturation လုပ်ပြီးတဲ့အခါမှာစီလာ setting ဖြစ်မဖြစ်ကိုတခါလေးစစ်အားစီးလုပ်ပေးုံနဲ့မက
Hello Professor 안녕하세요
ကျူတွေလာရောညှိတွေဖြစ်စေတယ် hydroxy appetite ကိုလည်းထုတ်ပေးတာဖြစ်တဲ့အတွက်
Hello Professor 민 안녕하세요
Hello, hi. Nice to meet you.
Nice to meet you
Nice to meet you all.
Mm-hmm.
ဒီလေးစတော့မလားရဲရင်
ဟုတ်ကဲ့ဆရာ
ဟုတ်ကဲ့
ကျွန်တော်ကနည်းနည်းလေးဆရာကိုနှုတ်ဆက်လိုက်ပါအောင်ဆရာ
ဟောနှုတ်ဆက်လိုက် okay
ဟုတ်ကဲ့ပါဆရာဒီနေ့ webinar ကိုတက်ရောက်လာကြတဲ့ဆရာတို့ဆရာမအားလုံးပဲမင်္ဂလာပါ webinar လေးကနေကြိုလိုက်ပါတယ်ကျွန်တော်ကတော့ဦးတုံစမစ်မြန်မာ product specialist ဒေါက်တာရဲရင်ဖြစ်ပါတယ်ဒီနေ့ webinar လေးရဲ့ title လေးကတော့ an update on hydraulic bioceramic materials in endodontics ဖြစ်ပါတယ်ဒီ calcium silicate ကိုအခြေခံပြီးထုတ်လုပ်ထားတဲ့ hydraulic bioceramic material ကို endodontic နယ်ပယ်ထဲမှာပြီးခဲ့တဲ့25နှစ်ကျော်ရဲ့အမိတ်ဆက်ပေးခဲ့ပြီးဖြစ်ပါတယ်တမှုထူးခြားတဲ့ biocompatibility နဲ့ sealability တွေကြောင့်ကမ္ဘာတဝန်းသွားတဲ့ဘက်ဆိုင်ရာဆရာဝန်တွေလက်ခံအသုံးပြုနေကြတာဖြစ်ပါတယ်ဒီ bioceramics material ကို perforation repair root and filling vital pap therapy regenerative endodontic treatment root canal filling အစရှိတဲ့ dental pap နဲ့ဆက်ဆက် tissue တွေကုသမှုပေးတဲ့ endodontic treatment တွေမှာတွင်တွင်ကျယ်ကျယ်အသုံးပြုလာကြတာဖြစ်ပါတယ်ဒါကြောင့် hydraulic bioceramic material တွေအကြောင်းကိုပုံမသိရှိထားလေမျိုးဆက်သစ် endodontic material တွေပုံမတိုးတက်ဖို့အတွက်ကိုတွန်းအားတစ်ခုဖြစ်လာစေမှာဖြစ်ပါတယ်ဒီနေ့ webinar လေးမှာတော့ endodontic treatment တွေအတွက်နောက်ဆုံးပေါ် bioceramic material တွေနဲ့ clinical လက်တွေ့အသုံးချနည်းတွေကိုပို့ချပေးသွားမှာဖြစ်ပါတယ်ဒါအပြင်လက်တွေ့အသုံးပြုတဲ့အခါမှာပုံမလွယ်ကူစေမဲ့အသင့်ရောဆက်ပြီးသား premix bioceramic materials တွေအကြောင်းကိုပါအဓိကအသာပေးပို့ချပေးသွားမှာဖြစ်ပါတယ်ဒီနေ့ webinar မှာ main speaker ကတော့ Professor Kyun San Min ဖြစ်ပါတယ် Hello Professor
Hello.
Can you
Thank
please introduce yourself for a little bit?
Okay. Hello, I'm Kyungsan Min, and last name is Min, and I'm working in Jeonbuk National University as a professor, and I do my research and educate my students as well. And mainly, I do clinical work every day, not every day, 3 days a week, and my main work is endodontics and also restorative dentistry, such as the resin filling or the crown, something like that. So I'm really happy to meet you guys here online, and I'm very happy, also happy to introduce the bioceramic material launched by Maruchi and my favorite materials as well. And so thank you for inviting me online, and I hope I can share my knowledge with the dentist in Myanmar, and I hope it will help you with understanding the bioceramic material better than now. Okay, it's my introduction by myself, and honestly, I don't know much about Myanmar, but I searched the internet, and Myanmar is much bigger than Korea in territory, and more than 6 times bigger than Korea. So I didn't know that Myanmar is very big. Myanmar is really bigger than I expected. And so I really want to visit Myanmar in the near future, especially Yangon, the capital city, and other places. And thank you for inviting me. Okay, that's all.
Thank you, Professor, for giving us the time. We are welcome you anytime.
Okay. Okay.
ဒီနေ့ webinar လေးရဲ့ moderator တွေကတော့ဆရာကျော်မိုးနဲ့ဆရာပြည်ဟင်းထွန်းတို့ပဲဖြစ်ပါတယ်ဒီ webinar လေးကတော့မကြခင်ကျွန်တော်တို့စတော့မှာပေါ့နော်ဒီ webinar လေးမစခင်မှာကျွန်တော်တို့ဦးတုံစမစ်မြန်မာကနေပြီးတော့ဒီပြန်သွင်းတဲ့ bioceramic material လေးရဲ့ promotion price လေးပေါ့နော်အဲ့ price လေးပြောကြားပေးဖို့အတွက်ကျွန်တော်တို့စေတင်ကမြန်မာလေးနန်းဝင်းမုံအေးကိုကျွန်တော်လှည့်ပေးပါပေါ့နော် Hello မြန်မာလေး
Hello
မြန်မာလေး screen လေး share ပြလို့ရပြီနော်
ကဲပါမင်္ဂလာပါရှင်ဒီမှာတော့ဦးတုံစပစ်မြန်မာ Sales Executive နှုတ်မွေဖြစ်ပါတယ်ရှင်ခုဝနာလေးမှာ hydraulic bioceramic material နဲ့ပတ်သက်တဲ့ products တွေရဲ့ promotion ကြောင်းကိုမိတ်ဆက်ပေးတော့မှာဖြစ်ပါတယ်ရှင်ဒါလေးကတော့ညီမတို့ဦးတုံစပစ်မြန်မာတင်သွင်းတဲ့ endoCMT လေးတွေအသုံးပြုပြီး RCT treatment ပြုလုပ်ထားတာလေးတွေပါဒါလေးကတော့ endoCMT လေးဖြစ်ပါတယ် endoCMT မှာဆိုရင် premise type နဲ့ missing type ဆိုရင်လည်းမျိုးလာပါတယ် premise type လေးမှာ 2 gram ပါပါတယ် missing type လေးကတော့ 300 mg ပါဝင်ပြီးတော့ one time use ဖြစ်ပါတယ်ဒီ endoCMT လေးရဲ့ပုံမှန်ဈေးနှုန်းလေးက 2,800 ကျပ်ဖြစ်ပါတယ်အခု webinar မှာဆိုရင် promotion price 2,000 ခွဲနဲ့ရရှိမဲ့ပြင် 8,000 တန် missing type လေးတစ်ထုပ်ပါလက်ဆောင်ပေးတော့မှာဖြစ်ပါတယ်ရှင်ဒီတွေ့ရ item လေးကတော့ endoCMT လေးဖြစ်ပါတယ်သူကတော့ premise type sealer လေးဖြစ်ပါတယ်သူရဲ့အတိအအားသာချက်ကတော့10မိနစ်ကနေ12မိနစ်အတွင်း setting ဖြစ်သွားတဲ့အတွက် obturation လုပ်ပြီးရတဲ့တခါတည်း sealer setting ဖြစ်မဖြစ်ကိုစစ်ကြည့်လို့ရနိုင်ပါတယ်အခြား sealer တွေလို setting ဖြစ်ဖို့နိုင်ရီကြအောင်စောင့်စရာမလိုတဲ့အတွက် single visit RCT treatment အတွက်ပိုအဆင်ပြေစေပါတယ်ဒီ endoCMT မှာလည်းခုန endoCMT လိုမျိုး 2 gram ပါဝင်ပါတယ်သူ့ရဲ့ပုံမှန်ဈေးနှုန်းလေးကတော့ 2,800 ကျပ်ဖြစ်ပါတယ်ခု webinar မှာဆိုရင် promotion price 2,000 ခွဲနဲ့ရရှိမဲ့ပြင် 8,000 တန် missing type ထုတ်ပါလက်ဆောင်ရရှိမှာဖြစ်ပါတယ်ဒီ endoCMT ရော endoCMT နှစ်ခုလုံးမှာ X-ray ရိုက်တဲ့အခါမှာ video opaque ကောင်းတာကြောင့်စီးလုံးမလုံးခေရှာရှင်းရှင်းလင်းမြင်နိုင်ပါတယ်ဒီနောက်ဆုံး item လေးကတော့ endosonic blue လေးဖြစ်ပါတယ်ဒီ endosonic blue တွေက wireless ultrasonic irrigation device လေးဖြစ်ပါတယ်သူ့ရဲ့ပုံမှန်ဈေးလေးကတော့$900ဖြစ်ပါတယ်ဒီ webinar မှာဆိုရင် original price $900နဲ့600တိ short ပေးမှာဖြစ်ပါတယ်ကြအပြင်$60တန် endosonic tip ကိုပါလက်ဆောင်ပေးတော့မှာဖြစ်ပါတယ်ဒါလေးကတော့ညီမတို့ကုမ္ပဏီကနေဒီ webinar ကိုတက်တဲ့ဆရာမတွေအတွက်ပြုလုပ်ပေးထားတဲ့ special promotion တွေဖြစ်ပါတယ်ဒီ promotion လေးတွေကိုတော့ခု webinar ပြီးရချိန်ကစပြီးတော့မနေ့ပြန်အတွင်းမှာဝယ်ယူမှလာရရှိနိုင်မှာဖြစ်ပါတယ် ဆရာမတို့နဲ့ဒီ product တွေကိုဝယ်ယူမယ်ဆိုရင်ညီမတို့ Udo Smith မြန်မာကိုအချိန်မီဆက်တင်နိုင်ပါတယ်ရှင်ကျေးဇူးအများကြီးတင်ပါတယ်ရှင်
ကျေးဇူးတင်ပါတယ်ညီမလေးဟိုဆရာတို့ကျွန်တော်တို့စတော့မှာဆရာတို့ဆရာကျော်မိုးပေါ့နော်ဟုတ်
ok
အဲ့ဆိုရင်ဆရာတို့ဒီမစခင်လေးမှာပြောစရာလေးတွေလေးရှိသေးရင်ဆရာတို့တခါလေးပြောလို့ရပါတယ်ဆရာ
ဟုတ်ကဲ့မင်္ဂလာပါအားလုံးပဲတွေ့ရတော့ဝမ်းသာပါတယ်
ဟုတ်မင်္ဂလာပါဆရာ
အဲ့တော့ကျွန်တော်တို့ကအရင် Rucan နဲ့ Sealer တွေ repair material တွေအများကြီးသုံးခဲ့တာပေါ့အဲ့တော့အရင်ကတော့ GI တို့ရိုးစုံသုံးခဲ့ပေမဲ့ခုနောက်ပိုင်းမှာတော့ Bioceramic era ကိုရောက်လာတယ် Bioceramic time ကိုရောက်လာတဲ့အချိန်မှာ Bioceramic material တွေနိုင်ငံထဲမှာလည်းကျွန်တော်တို့ဝယ်လို့ရလာတယ်တင်သွင်းမှုရောင်းချတာတွေလည်းရှိလာတယ်ဆိုတော့ Bioceramic material တွေနဲ့ပတ်သက်ပြီးကျွန်တော်တို့သုံးတဲ့နေရာမှာ indication ဒီသိဖို့လိုမယ်လို့ထင်ပါတယ်Bioceramics ဆိုတာလည်းကျွန်တော်သိတဲ့အတိုင်းဟိုးတုန်းက gray MTA white MTA တွေကနေစပြီးတော့နောက်ပိုင်းမှာ calcium enriched mixture တို့ bio aggregate တို့ biodentine တို့မျိုးစုံပဲနောက်ပိုင်းမှာ sealer တွေမကဘဲနဲ့ putty type repair material တွေပါပေါ်လာတာဆိုတော့ကျွန်တော်အမြင်မှာတော့ general practitioner တွေအတွက်ဒီ webinar ဟာအကျိုးရှိပြီးတော့ဘယ် material ကိုဘယ်နေရာမှာဘယ်လိုသုံးသင့်တယ်ဆိုတာကိုinformation ပေးနိုင်လိမ့်မယ်လို့ယူဆပါတယ်ခင်ဗျအားလုံးပဲကျေးဇူးတင်ပါတယ်
ဟုတ်ကဲ့ဆရာအဲ့ဆိုရင်တော့ကျွန်တော်တို့ webinar လေးကိုဒီ lecture လေးကိုစလိုက်တော့မယ်နော် Professor Min shall we begin the lecture
Oh yeah, okay. Can I share my presentation? Okay. Can you see my presentation?
yes
Yeah.
we can
yes
Okay. 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 Good.
你先给我嘞，你那我买我对呀，你的是呀，我的。他里面应该是不对。有。我都买到的，对呀，有按到。
mình có một lần để pháo để bao lại đi theo thế này thì bao không phải pháo này bao đi lại đi không mà sao rồi đấy anh em pin nào
ဟို mic လေးပွင့်နေတယ်ညီမတို့
ဟုတ်လေမလို့လေငါတို့လူဆရာဝန်တရားကိုရစားအောင်ပေါင်းလိုက်ရ
ညီမတို့ရေ mic လေးပွင့်နေတယ်
ဒီလေးပိတ်လိုက်ပါ
Is
ဘာ
there
လို့ကိုကရပေါင်းတာဟုတ်ခုလို့ပြောစားအောင်မဒီလောက်ဒီလိုက်အကုန်
ဆရာ host ကနေမိုက်ပိတ်လို့ရတယ်နော်ဆရာ
လိုက်တာပို့ငါတို့ကပို့ပြီးတော့ပြီးကြတယ်နေသူ့အဆောင်နေဒီတက်ရမှာမဟုတ်
okay? Yeah. Very.
sorry for some technical difficulties
Yeah. They don't recognize their speaker is on. Okay, speaker is on. Okay. Today I heard that there's no interpreter today. As you know, you and I, both of us, are not native English speaker. So to facilitate the communication, I'm going to talk a little bit slowly before, so to let you know to understand easily. Okay. Okay. Today's topic is an update on hydraulic bioceramic materials and endodontics. As you know, I'm an endodontist, and my practice is limited to endo. But while I'm at the endodontic treatment, the bioceramic material is a very excellent material to do my endodontic treatment. So I really want to introduce these nice materials to you. Before that, I need to let you understand what the bioceramic is. So I want to talk a little bit about the history about the MTA and so-called bioceramic, and it's like I'm going to introduce some journal articles and published in the journal, and to make you understand. Okay. In 1993, long time ago, November 1993, an interesting article was published in the Journal of Endodontics. As you know, the Journal of Endodontics is one of the most popular journal in endodontic field. So the topic, the title of the article was a sealing ability of a mineral trioxide aggregate for repair of lateral root perforation. Actually, we are very familiar with the mineral trioxide aggregate at this moment, but at the time, it was very interesting and strange word. So nobody knows what it is. So the author, the corresponding author of this article was Mahmoud Turabinejad. Please remember this name. And the first author is Dr. Lee, a professor in Korea. He visited the Loma Linda University, California, a long time ago as a visiting professor, and they do co-work to develop this MTA. And this article is the first article to introduce the MTA to MTA, actually. So this article deals with the sealing ability of the lateral root perforation. Actually, root perforation is a tragic phenomenon, usually done by dentists. So it is called iatrogenic. So it is a tragedy, and so nobody wants to see the perforation happen. But so most of the tooth undergone the perforation was extracted, actually, a long time ago, but now we don't extract anymore due to the MTA. Okay, so I want to explain what the MTA is. Actually, MTA stands for mineral trioxide aggregate. Trioxide is very important in this word. Actually, tri means three, and oxide is oxide. So it means there are 3 oxides in this material. So we call this MTA. So what is 3 oxides? First one is calcium oxide, and second one is silicon oxide. And we can react the 2 materials in the furnace, and cement is come out. So we call this cement tricalcium silicate material, and we usually call Portland cement. And then what is the third oxide? This is the bismuth oxide. Actually, as you know, if the material is used for endodontic filling material, it should possess a radiopacity bigger than 3 millimeter aluminum. So we need to put some radiopack material, usually the heavy metals. So Dr. Turabinejad put the bismuth oxide into the cement to provide radiopacity. So we call this MTA, and this is launched by the dance pride Tulsa long time ago, as the name is ProRoot. I'm going to show you the Dr. Turabinejad. He's Iranian, actually, and he went to the States to study 70-something, and he became a professor in Loma Linda University in California. And after he developed this material, many researchers and many dentists went there to study the MTA. Many Korean dentists went there as well. So we call this MTA. But however, the problem is that the MTA is not scientific word at all. Actually, this is made by Dr. Turabinejad, and this is not a scientific word at all. And this material is called calcium silicate-based material, scientifically, chemically. So because it is composed of calcium silicate. Actually, this Portland cement was actually developed by English bricklayer Joseph Aspdin, 1824, very long time ago, around 200 years ago exactly. And he developed this material, and the people found that this cement was very similar to that of the island of Portland Island, the stone in the Portland Island. So people start to call this cement as Portland cement. And now, until now, we call this material Portland cement. And this is building material. So we can build the architectures and buildings very fast, quickly. Now, apartment buildings and something like that. And Dr. Turabinejad bring this material into the endodontic field, and it became a very excellent material. So we mix the cement with the water, and the hydration reaction occurs, and finally the calcium silicate hydrate came out by mixing the material with the water. So, and the calcium silicate hydrate and calcium hydroxide and heat is produced. So we after mixing, we deliver this material into the tooth, and we call this material MTA now. So the first commercial material of MTA is ProRoot, and this is the mixture of Portland cement and bismuth oxide, as I mentioned before. And Dr. Turabinejad, they get the patent, US patent in 1995, finally. So this material, MTA, has a very nice sealing ability and very excellent biocompatibility. But the handling property is very hard to handle because we need to mix with water, and it does not have viscosity at all. So it is very hard to deliver into the site of the interest site. And also it produced the tooth discoloration. It discolored the tooth as a black pigmentation something. So it is very hard to use this MTA into the anterior teeth. It's the problem. So when you use the MTA for the pulp capping or the root canal filling into the anterior teeth, the tooth became dark shade, and the patient complained about it. So the researchers and dentists to try to find the solution. So at first time, the dentist thought that it is because of the color of the cement, the gray color. So they changed the cement into the white cement. So they produced the white MTA. However, actually, this effort was in vain because the color of the cement was the real cause of the discoloration. So researchers and dentists try to find the real reason, real cause of the discoloration, and finally they found the cause of the discoloration was that the radio pacifier named bismuth oxide included in the MTA. Because bismuth oxide is really heavy metal, and it is a very highly soluble, and if it is mixed with the water, and it can bind to the collagen and the dentin, so it became the dark colors. So the people try to find alternative of this bismuth oxide, and they found a very nice alternative. That is zirconium oxide. So at the time, from that time, the bismuth oxide is was not used for pulp capping material, because but however, the zirconium oxide is much lighter than zirconium oxide, because it is heavy metal as well, but its molecular weight is very low. So to achieve the same value of the radiopacity with bismuth oxide, we need to put the much more amount of zirconium oxide into the MTA. So what about how much amount of the zirconium oxide? More than 50%, believe it or not. So the problem is arise that we cannot call this material as a calcium silicate based material anymore. So we need to find a more appropriate terminology. As you know, this material, the MTA, is mixed with water, so it is set in the presence of the water. So we call this kind of material as hydraulic cement. This is originated from the concrete science, so it is still not appropriate for the medical science, such as the dentistry or the endodontics. So people find another suitable word like bioceramic. Bioceramic is a biocompatible material used for repairing or replacing damaged hard tissue, such as like the calcium phosphate, zirconia, hydroxyapatite, all the biocompatible materials. So we are going to call this MTA, or calcium silicate based material, to the hydraulic bioceramic. So I'm going to summarize the terminology. MTA is developed for use as a dental root repair material, and it is a mixture of Portland cement and bismuth oxide. This is definition. And calcium silicate is a scientific word indicating a calcium oxide and silicon oxide mixture. And hydraulic cement is the inorganic materials is react with water, and this material hydraulic cement. And bioceramic are ceramic materials that are biocompatible. So very confusing, but I suggest you to call this material as a hydraulic bioceramic. But MTA is okay, calcium silicate is okay, but I'm not trying to say that you should not call this material MTA or the calcium silicate. Okay, it's okay, whatever. But you should know that scientifically, at this moment, hydraulic bioceramic is the most appropriate terminology. That's the reason why I call this material hydraulic bioceramic instead of the MTA, this lecture. Okay. Okay, now I'm going to move on to the products. Maruchi produced these 5 bioceramic materials currently. The first one, so I'm going to explain these materials from now on. The first one is endosem MTA. It's the powder type bioceramic. It is powder, and you can mix with the distilled water and mix. Actually, endosem MTA is composed of dicalcium silicate and bismuth oxide and gray color. So you should be careful when you use this endosem MTA in the anterior tooth, because it can discolor the tooth, because as you know, because bismuth oxide is included. After that, Maruchi developed the white-colored powder type bioceramic named endosem zirconia, endosem zero. Okay, as the name implies, it includes the zirconium oxide is included as a radiopacifier, so it never discolored the tooth anymore, unlike the original endosem MTA. And the color is white, a little bit ivory or something. And so it is also a mixture type. So endosem and endosem zirconia, you should mix these materials with water and the chair side and apply to the patient. Okay, got it. But as you know, the mixing procedure is very complicated in your clinic. So the researchers and dentists try to find the more convenient way to apply the bioceramic into the tooth root canals or onto the pulp, dental pulp, by the new technology. It's very easy to make, but theory, okay, you can mix with a bioceramic powder like the calcium silicate with non-aqueous vehicle, not water. Just because if it is mixed with the water, it can react and it sets unwanted sets. So to avoid the unexpected setting, so you can mix with non-aqueous vehicles such as polyethylene glycol, propylene glycol, something like that. And we can put this mixture into the watertight syringe. And watertight syringe, it is never react with water adjacent to the atmosphere. So it is, so we call this material pre-mixed, because we don't mix, don't need to mix this powder with water anymore, and it is because it is pre-mixed by the manufacturer, and also it is inserted into the syringe, injectable syringe. It is injectable, so it is very easy to apply. It has a very good advantage in terms of the delivery. So this type of material is, first one is endoseal MTA. Endoseal means that endo and seal means that root canal. It is root canal filling material. It is a sealer, not pop capping material, root and filling material. It is sealer. So you need to use this material only when you fill the root canal. It is a premix type, and it includes bismuth oxide, also is the zirconium oxide. So you need to be careful when you use it in the anterior teeth, but not severe discoloration, and it is also gray color. And Endosan MTA premix is very nice one. It is not sealer. You should never use it when you fill the root canal, because it is very viscous and the flowability is not so good. So it is not suitable for the root canal filling. So it is used as a root end filling and retrograde filling, as you know, and the pulp capping or the vital pulp therapy, such as the partial pulpotomy, and it is also white color because it includes the zirconium oxide. Can you look hello. Excuse me. Can build the unexpected noise. Okay. Okay. So very irritating. Okay. Charlie? Is there any problem in the communication? Excuse me, Charlie. Okay. So okay. So you can make
Okay, I think.
okay. Okay, good. Okay, so you can consider this endothelium MTA premix as a injectable MTA. So instead of the mixing, you can apply this material directly into the perforation and pulp capping or something, root end filling. So, and this is white endothelium MTA. As I mentioned, seal implies the sealer, so it is used for the canal filling, not pulp capping or not root end filling. So you need to distinguish the endothel and endostem. And when the name is endostem, you need to use it only for the root end filling, pulp capping. And when you see the seal, endothel, you need to use it only for the root canal obturation as a sealer. So white endothel MTA is a premix type bioceramic sealer, and it contains zirconium oxide and is a white shade. And but unfortunately, it is not available in your country because Maruchi export this material to Dense Price Sirona, and Dense Price Sirona is launch this material and changing the name to the AH Plus Bioceramic sealer. So the same material, white endoseal MTA and AH plus bioceramic sealer is same. So if you want to use the white endoseal MTA in your country, you need to use the AH plus bioceramic sealer. So so it is unfortunately, but actually whatever, and I cannot help it. Okay. So when you use the premixed bioceramic material, you need to be very careful when you store this material, when in the store this material. Maybe in the envelope there is white cover is provided. So after the use, the material by injecting and then remove the needle and the cap, this white cap, and because otherwise the material is easily set. So to avoid preventing the unexpected setting, the white cap is very important. So with some dentists sometimes put this the rubber cap into after the use when the store. It never work. It doesn't work at all. So the material will set, and you should take away and dump it into the garbage. So to prevent to save the money, you need to do always cover this material with the white cap. Don't forget it. Okay. Okay, from now on, I'm going to show you the clinical application of the hydraulic bioceramic. From now, it's very I'm going to show you many pictures, clinical pictures, and the movies, the video clips. Okay, as I mentioned, this material is a hydrophilic material because it works when it is mixed with water. So it is used for in the presence of the moisture, like the blood or the tissue fluid. So it can be used for the root end filling, perforation repair, or direct pulp capping or something. So it is not susceptible to blood. Okay, so, but I don't mean that you can use this material so much amount of blood or something, but you need to control the hemorrhage first and then use this material. It should not be mixed with the blood. Okay, so it is hydrophilic, but avoid the much amount of blood. So I'm going to show you how to use the bioceramic for the root and the filling. Okay, root and filling is part of the periapical surgery. When the periapical lesion is present, exists, and you can do the periapical surgery. So you can cut the apex, cut the apex out for 3 millimeters, and then retrograde filling is done until the 3 millimeters as well, and remove the gutta percha like this. Yeah, and then dry the retrograde root end cavity, and you can put the endostem MTA like this. Actually, I prefer the endostem MTA for root end filling method because it is packable and it can be filled in the retrograde root end cavity effectively. So, but I use the manual plugger for the purpose. If you take a look here, yeah, you can see the manual plugger I use, and it's very easy to use. Yes, like this, yeah. 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 Well, I can see the well-filled root end cavity with the MTA, and I checked it by using the micrometer. And this is the post-OP, and you can see the well-filled root end cavity like this. So I'm going to show you how to use the manual plugger. Manual plugger consists of two parts. First one is metal plugger, and the second one is the silicone Teflon tube. Tube is can be assembled like this, and after that, there is still space for the material, and you can mix the MTA like this, and you can insert the material like this by tapping the material with the manual plugger, and in the empty space, the MTA can be inserted. Then it's ready to use. So you can ask your hygienist assistant to mix the MTA and put the MTA into the manual plugger, and then you can use it. I'm going to show you one more time. This tooth has a periodical lesion because the root canal treatment can be done appropriately because of the ledge exists. Ledge exists here, so the periodical lesion cannot be healed. So I decided to periodical surgery for the basal root of the tooth. So after the root end preparation, and then I fill the cavity, root end cavity with MTA using the manual plugger like this. And so when you fill the root end cavity with endostem MTA, please use this manual plugger. It's available in Dentsply Sirona or PD Dental, or I don't know, but yeah. And then after 1 year and 3 months, you can see the well-healed, very nicely healed periodical lesion, and so the result is very good. And I'm going to show you the root perforation repair. The patient, the old patient, male patient, complaining of the dull pain on his right upper molar area, and I diagnosed as a periapical abscess, and I decided to do the retreatment. So, but while I measure the working length, I found that there was perforation. I didn't make the perforation ever. So it was done by previous dentist, I think. So I repair the perforation using the MTA, and I used very specially designed equipment like this because perforation site is located a very deep part of the root canal, so I need to use very very thin material, thin equipment to insert the material effectively, and yeah, like this. And after that, you can see the well-filled perforation site with the bioceramic, and the patient symptom disappeared, and the prognosis was really good. So you can repair the perforation effectively with bioceramic material. So the equipment I used in this case was a MAP system. MAP system is also available Dentsply or the other, many companies produce this equipment. So if you have affordability, you can buy it, and so you can use it very effectively with the powder type material. And you can repair the perforation by using intentional replantation. As you know, intentional replantation means that you can extract you extract the tooth intentionally and do something, and then replant the tooth on the original site. So early 20 something male patient presented to my clinic complaining of the dull pain and sinus tract. So I took the diagnostic X-ray and found there was radiolucency adjacent to the mesial root of the right lower second molar, and I didn't know that the reason why this radiolucency was occur here. So I took a cone-beam CT scans, and I found a very interesting feature. Actually, in the middle root level, there was some defect on the root. So after the dental history taking, he got the orthodontic treatment 1 year before, and then I speculated that the previous orthodontist placed the mini screw for the anchorage, but he or she placed the screw wrong place, the root surface. So the defect occurred. So I did the root canal treatment, conventional root canal treatment, and I decided to do the intentional replantation. So I extracted the tooth, and I found the defect made by the orthodontic mini screw, and I filled the perforation site with the endostem MTA, and I also did the root end resection and root end filling as well, and I replanted the tooth immediately. And after 2 months, the patient's symptom disappeared, and the tooth was the healing occurred, and patient symptom is gone. And 5 months, 1 year, there's no problem, and sinus tract is also disappeared, and there's no problem. So I did a crown, zirconia crown here, and I still tried to recall the patient, but the patient did not come, because I speculated that maybe, he has no problem. Okay. As you see, for the application of bioceramic, delivery is very important, because to deliver this material to the accurately, we need a very specially designed equipment. So it is very expensive and hard to acquire, and so premixed premixed bioceramic is very, very useful for the delivery, the application. So I'm going to show you the advantages of premixed bioceramics. It is premixed and thus ready to use. So we don't need to mix anymore. So sometimes the operator error can occur because we can mix inadequately, and assist is not familiar with mixing or something. So many problems may occur when you mix the powder with water. And pre-mixed material have the benefit of homogeneous consistency, and no cross-contamination and easy delivery to the very non-accessible areas, and handling properties, the handling characteristic is the increased. So many advantages you can get. So I'm going to show you a very interesting case with the premixed bioceramic. Actually, 30-something of female patient came to my clinic and complaining of facial pain of her left face here. And interestingly, she told me that the pain increased when she bent over or they run into the treadmill like this. Because so I suspected the maxillary sinusitis, but the endodontic treatment looks nice, and so I don't find any problem in this periapical radiograph. However, when I take the COM-beam CT scans, I found very serious mucositis. The membrane is inflamed, and there is some so I found some perforation and the lateral root surface. So I call this problem as a maxillary sinusitis of endodontic origin. It's a MSEO. I call this problem MSEO from now. Okay. So I decided to root canal treatment and then repair the perforation with a premixed bioceramic named is endoCMT premixed. So I opened the access cavity and I found the perforation site here. So I decided to use the premixed one, so I don't need any specially designed materials, because I can inject the material into the perforation site precisely. So I placed the endoCMT premix into the perforation site and the stamp with the paper point, and then I took the X-ray and I verified that the endoCMT premix is placed adequately in the perforation site, and I filled the root canal with gutta-percha and sealer. And after 6 months, the patient has no symptom at all. And when I took the CWCT scans, the mucositis is gone. Perfect. I'm not trying to say that the endoCMT premix solved the problem. Never. The powder type would work. So whatever you want, you can use whatever you want. But what I'm saying now is if you use the premix type bioceramic, it's much easier to manage the problem, such as perforation repair. So please try this premixed type of material when you get the face to the root perforation. Okay, we can now move on to the BioTherapy therapy. Actually, for the BioTherapy therapy, calcium hydroxide was the gold standard for a long time, but now the paradigm shift because hydraulic bioceramic materials developed. This is brief history. Actually, the bioceramic material MTA was appeared first time in 1993, and this material get the U.S. patent in 1995, and for the first literature was published regarding the pulp capping in 1996, and in 1995 FDA approval was achieved, and finally 1999, the end of the 20th century, the per-root MTA is first launched in the United States, and after that, for a long time, more than 15 years, there is so many evaluation was done, and so 2015, the first meta-analysis was occurred and published compared to the calcium hydroxide in Journal of Endoontics, and it is now actually the MTA is found to be better than calcium hydroxide. So now the MTA, the bioceramic, is gold standard for the pulp treatment. Okay, I'm going to show you the clinical case with the premixed bioceramic. In the diagnostic X-ray, I found the dental caries on the proximal surface, of distal surface of the second premolar, and I removed the caries with a high-speed round bar or low-speed round bar, and accidentally the pulp was exposed like this in axial wall. It's very hard to manage because please imagine that to repair this material with a powder type MTA, because it is very hard to it's hard to place exactly. So, but however, if you use premixed type, it's very easy. If you see this picture, you can see the injected material like this exactly on the exposed pulp. So yeah, it's very easy. So, but you should place the wet cotton pellet onto the material for 3 minutes. Why? Because we need to induce the hydration reaction for the setting. But it's not set completely, but we need to induce get the initial setting, because we need to fill the cavity with the composite resin. So we need to the acid etching or priming and bonding. So it should be set initially. So for the initial setting, the application of the wet cotton pellet is required for 3 to 5 minutes. So if you place the cotton pellet onto the material, you can have some coffee or something, and then come back, and you can do the the restoration procedure. So you can see the initial set material, and you can place the matrix and then etch. But you should etch the only enamel surface, because to avoid the washing of the material, and then priming and bonding, and resin filling is done, and polish, and this is post-op. So if you use the premix type, injectable type of MTA, the pulp capping is very easily done. So 1 year after, I recall the patient, and the patient has no symptom and no pathosis occurred. So there's no problem. Okay, good. And the patient complained of the dull pain after the resin restoration procedure in the previous dental clinic, and you can see the large pulp spaces. So I suspected the pulp exposure invisible by naked eyes. So I removed the previous composite resin restoration, and I found this, very tiny pulp exposure. So that's the reason why the patient has dull pain. So this is a pulp horn exposure. So I'm emphasize the use of dental operating microscope in your clinic. I don't know if the microscope is available or widely available in your country, but I strongly suggest you to use the dental operating microscope. And under the microscope, I place the premixed bioceramic endoceramic premix onto the site, and then I put the wet cut pellet for 3 or 5 minutes, and then I restore the tooth with composite resin here, and this is post-OP. And partial pulpotomy is also very good candidate for use of the premixed bioceramic. Actually, this the 14-year-old boy came to my clinic with dental caries, but I found that the root canal anatomy is very complex and very hard to perform the root canal treatment. So this is the initial photograph, and instead of the root canal treatment, I just remove the caries and the inflamed pulp, partially shallow pulpotomy, and then place the MTA premix, endoceramic MTA premix here. Then this is post-OP, and after 3 months, reparative dentin was formed underneath the material, and 1 year after, you can see the remarkable, very well-formed the dentin bridge underneath the endoceramic premixed. So the treatment was successful. And pulpotomies can be done with a premixed bioceramic. When you do the access cavity preparation, and you can see that the pulp is removed all dental pulp and the coronal part, and then place the MTA here and restore the tooth with composite resin. This is post-OP. Very easy to do with the premix one. Okay, so actually, MTA has the much more advantages compared to calcium hydroxide because of it has a very high biocompatibility, and so cytotoxicity is very minimal, and it has a very good sealing ability, and so is an excellent marginal adaptation. So it provides bacteria tight seal. So compared to other materials, this MTA, the bioceramic, provides a very complete sealing. So bacteria cannot enter the pulp space. So the game is gone. The MTA win. Okay. So finally, I'm going to introduce the root canal obturation with the bioceramic sealer. So you can use either the endothelial MTA or white endothelial MTA, but as I know, white endothelial MTA is not available in your country. So unfortunately it's not available, but so you can use the EndoSeal MTA, the original EndoSeal MTA. There was very interesting survey, international survey for the use of the calcium silicate sealer, MTA sealer in the world, over the world. So the survey was done from the dentist all over the world, but mainly the main part is North America and Europe, but the Asian countries was included as for the survey, and around 80% of the dentist was endodontic specialist, and 20% of dentists were general practitioner. And it was published in the 3 years ago, but at the time, more than 80% of the general dentist was already heard of the bioceramic sealer, BRCS is bioceramic root canal sealer, and around almost 100% of the endodontist has already heard of the bioceramic sealer. And for the usage, more than 40% of the general dentists has already used the bioceramic sealer, and more than 60% of the endodontic practitioner, endodontic specialists have used the bioceramic sealer. And the main reason of the use of bioceramic sealer is that they think that it is biocompatible and it has a superior physical chemical properties compared to other sealers. And so okay. So what I'm saying is that bioceramic root canal sealer is very, very popular now. So it is available all over the world. So, okay. Okay, by the way, let's change the topic, okay, a little bit, okay. A 40-something of the male patient complaining of the dull pain and on her left lower molar area, and he called me often called me and complaining complain to solve the problem to me every day, because he's my younger brother, actually. Actually, 18 years ago, I did the root canal for him 18 years ago for the tooth. And the tooth was C-shaped and very hard to do, but at the time I was a graduate student and I was not familiar with endodontics a lot, and so but because he's my younger brother, I tried my best, and yeah, that's enough. So, but after 18 years ago, the tooth was extracted due to the periodontal reason, not endodontic, because you can see the granulation tissue here. And I asked the dentist who extracted the tooth and sent the tooth to me, and I made a specimen, and I made the sections, coronal, middle, and apical. And I found that the filling, canal filling was done very appropriately, nicely, even 18 years ago, from that time, okay. But as you see, that I used the lateral compaction with a resin-based sealer, but it lasts 18 years ago, 18 years. So, it means that lateral compaction with a resin-based sealer is okay. Okay, I suggest you to use the lateral compaction technique and resin-based sealer. It's fine, okay. But I suggest use the bioceramic. Why? I'm going to let you know the reason why I suggest the bioceramic sealer currently at this moment. Because it can be done by using single cone technique, you know. Lateral compaction technique or vertical compaction, we need to use the special spreader or plugger like this. But if you use bioceramic sealer, you can use it just a single cone and cut it out the gutta percha at the orifice level. That's all. It's very easy to do. So technically, I suggest you to use the bioceramic sealer. Very easy, yeah. Yeah. And this is the post-OP, and after 3 months, the frication lesion was completely healed. And but also you can use the bioceramic sealer with a vertical compaction technique as well. I put the endothelial MTA and the visual root canals of the maxillary and mandibular first molar, but it has an isthmus, and so I decided to use the vertical compaction instead of the single cone technique, like this. And then you can compact vertically with a plugger here, like this. And do not try to push a lot, because bioceramic sealer has a very nice sealing ability, so you don't need to apply the very compaction force. And then backfill with the gutta percha, like this. Yeah. Yes. And this is the result. And after 2 months, the bony lesion is healing now. So what I'm saying that you can use bioceramic sealers using single cone technique or one vertical compaction technique as well. That's no problem. It's up to you. But a single cone is also available. But when you use the resin-based sealer, single cone technique cannot be used. And the second point is moisture. As you know, the bioceramic sealer is not susceptible to moisture because the moisture is necessary to be set. So that means that you don't need to try your best to dry the root canal completely. Even though there's some moisture remained in the root canal, bioceramic sealer works well. So this is the research that shows that even the moisture remained in the root canal, bioceramic sealer exert its effect, is sealing ability well. So do not try to dry the root canal completely when you use the bioceramic root canal sealer. But when you decide to use the resin-based sealer, you should try your best regarding the dryness of the root canal. That's the main advantage. Another main advantage to use the bioceramic sealer, because we don't need to worry about the remaining moisture anymore. A third issue is minimally invasive endodontics. Nowadays, the root canal preparation amount is reduced because we have a very nice nickel titanium files, and we have the microscope. And so the dentist in the world, and especially endodontist, try to reduce the preparation amount. So we call this a minimally invasive endodontics. So as the root canal preparation is smaller, we cannot compact vertically anymore. So we can use a single cone technique, but if we use the resin-based sealer, single cone is no way. But if we use the bioceramic sealer, single cone is okay. So that's the reason why I suggest to use the bioceramic sealer in modern endodontics. So compaction, well, I don't know. So we don't need to compact the root canal gutta percha and root canal sealer anymore because we reduce the preparation amount because we are try to achieve the minimally invasive. So I love to use the ProTaper Ultimate, very small file. So this is sinus track here. I decided to do the root canal treatment with the ProTaper Ultimate. Very small size file here. And next one. I'm just to show you the preparation of visible root canal because of time is because of the time. Okay, and this is the F1 file, very small size, but due to the curvature of the root canal, I stopped the preparation in this stage, and I try to fill the root canal. But as you can see, I cannot insert the tip of the syringe needle because the preparation size is very small. So I just put the material, place the material only the orifice level, and I insert the gutta percha cone here like this. And I just cut the gutta percha at the orifice level, just a single cone technique. Just remove the excess gutta percha at the orifice level, and yeah, okay. And I just plug, use the plugger. Okay, this is the result. You can see very nicely manage the curvature, and the preparation size is not that big. So in this case, bioceramic sealer is the best choice because we need to use the single cone technique. So, and the last advantage, I think, is the biomineralization. Biomineralization means that if we use the bioceramic sealer, there is some mineralization occurs in the dentinal tubule. So if we fill the bioceramic sealer, the mineralization process occurred toward the dentinal tubule. So if we observe the dentinal tubule with a scanning electron microscope, we can see some kind of precipitate or hydroxyapatite crystals like this. And so we may speculate that this precipitate or this mineralization can very affect positively for the root canal filling. So that's the last reason why I suggest bioceramic root canal sealer instead of the resin-based or ZOE-based root canal sealer. Okay, this is the last slide. I'm going to show you my first case 8 years ago. My first case of using the EndoSteel MTA, the first bioceramic sealer in my life. So I just put the endothelial MTA here and just put the gut project count, insert the gut project count and another count. And I just cut out at the orifice level as usual. And that's it. And I just, yeah, it's not compaction, just trembling. And distal root is one canal. Oh, okay. Do not try to insert the sealer in the apical part because, you know, if you try to inject the sealer into the canal with a severe force, the high force, it can extrude it. It can be extruded beyond the root canal orifice. So it's not good. So please be careful not to extrude the material beyond the apical constriction. That's all. This is my first case. Very impressive case. And this is post-op, and this is 4 years later, and 7 years later is no problem. So I think the bioceramic root canal sealer is has the potential to be used as the best root canal sealer at this moment. So please, I suggest you change the sealer in your clinic from the resin-based sealer to bioceramic sealer. I showed a lot of advantages and is very good for your daily practice. Okay. Okay, I'm going to summarize my lecture here today. Summary for endodontic bioceramics means it is the adequate physical-chemical properties, and it has a favorable biological properties such as antibacterial and cytocompatibility and bioactivity, and and it has a nice sealing effect especially due to the biomineralization. And last but not least, it has a very nice handling property. So it's very easy to apply, easy to use. So I hope that you can use this material and you can this material adequately, and it can help you with making your practice better and better. Okay. I hope my lecture is okay for you, good for you, and I could help you to expand your knowledge about bioceramic sealer. Okay. Thank you for attention. Thank you.
Thank you, Professor. It's very helpful to us. Your lecture is very precious to us. Okay. We shall soon start the Q&A section immediately because it's bedtime already in your area, so I don't want to waste any more of your time. Yeah.
Okay.
So the question asked by Dr. Luangwei is that in partial pulpotomy, did you put the MD in partial pulpotomy? In partial pulpotomy, did you put the MD on the bleeding pulp tissue immediately, or did you wait after the bleeding is controlled? How did you do for the bleeding control?
Actually, bleeding control is a very important part for the pulpotomy. Even though I told you that MTA is very hydrophilic material, but I don't mean that it is applied to the bleedy dental pulp tissue. So hemorrhage control should be done adequately. So my tip is that you can put the cotton pellet soaked with the sodium hypochlorite, and for the 1 or 2 minutes, it's enough. And then when the hemorrhage control is done, you can place the MTA. Otherwise, it can be failed. So bleeding control is a very, very important step for the success of the pulpotomy.
Another question asked by Dr. Miyazanto is that, can I use capillary tip instead of the original tip in the package because the original tip is a little big? I mean, for the endosonic blue, I think. Yeah.
Oh, and the sonic blue. Oh, it's a little bit different topic of my lecture. Okay. And the sonic blue. Yeah. I didn't lecture in the sonic blue. What is the tip? What was it for the MTA application?
I will ask you directly from here. Is it okay, Doc?
Oh yeah, sure.
What I meant is the original tip in the endoceal MTA. I mean, the tip is a little bit too big. So I'm asking out of curiosity, because if I use the capillary tip instead of the original tip in the packaging, it should maybe I'm worried that it might affect the setting time or consistency of the material. That's why I asked that.
Oh yeah, okay. Okay. I'm going to show you my video like that. Okay. Okay. Can you see? Okay.
Yes, sir.
Okay. Okay, you can, if you see this, what I'm doing is that I do not insert the tip into the root canal, so deeply, because the flowability of the bioceramic is very high compared to resin-based sealer. So even though you placed the sealer around the orifice, not into the very deep part of the root canal.
Yes, sir.
When you insert the Galapagos cone, it can be inserted, placed into the apical part. If you take a look here, you can see the extruded sealer puff here, even though I did not insert the root concealer into the deep part of the apical part of the root canal. So what I'm saying is that do not try to use the very small tip, very tiny tip, because it's very hard to push use the syringe. So I recommend you to use the normal one included in the
Original package.
Yeah,
Yes.
yeah.
Thank you, sir. So the capillary tip is not acceptable then?
Yeah, not recommended.
Not recommended. Thank you, sir.
Welcome.
Another question is, in case of partial pulpotomy, sorry, how to apply bioceramic material with pressure or without pressure?
Without pressure, because pressure has nothing to do with the success of the the pulpotomy, because if you can inject the endocemented premix slightly, very small pressure, and then place this material onto the pulp, and then place the wet cotton pellet just without little pressure. Do not press. Do not apply a high pressure of because we need the enough amount of the thickness of the bioceramic. If you apply the high pressure, the thickness of the bioceramic is very minimized. So it is not good for the success of the VitaPulp therapy. So yeah, okay.
Another question is, did you wash with normal saline after bleeding control with sodium hypochlorite?
Absolutely, sodium hypochlorite. Sodium hypochlorite has advantages about regarding not only for the hemorrhage control, also for the disinfection. You know, disinfection that means that removing the bacteria, microorganism is a key factor for the success of the VitaPulp therapy. So please use the sodium hypochlorite around 1 to 5%. So it can help to remove the bacteria. It's a very, very, very important step for the success.
Another question is the setting time of the cilia in the root canal.
Setting time. Actually, we can distinguish the initial setting time and the final setting time. Final setting time is very long, as far as I know, but initial setting time is not that long. So you should not wait so long time when you apply the sealer. You should place the gutta-percha cone immediately after the insert the sealer. Okay, so initial setting time is can occur unexpectedly, so in a very short time. So yeah.
Okay, ဆရာတို့မေးချင်တဲ့မေးခွန်းလေးရှိသေးရင်လည်းပြောလို့လည်းရတယ်လို့မျိုးပေါ့နော်ဒီလိုမျိုး type ထဲမှာလည်း chat meeting chat ထဲမှာလည်းကျွန်တော်တို့ရိုက်ပေးလို့ရတယ်ပေါ့နော်ဒီ Another question is, thank you so much, Saya. Let me know we can use this material for RET.
Okay. Absolutely. Our regenerative endodontic treatment is now very popular because we have so many cases, especially in Asian area, because you know the immature root is occurred when the dense vaginatus, but as you know, dense vaginatus is occurred in the Asian people. So the Asian people Asian dentists are very interested in the RET. Okay, RET, MTA should be used because you know other material cannot be used because you know we induce the blood clot into the root canal space, and then we need to place the other material. But other materials are very hydrophobic, so it cannot work. It cannot work well in the presence of blood. So MTA is the best material for the RET. So after you induce the blood clot into the in the root canal, and you can select without pressure, you can place the endoOSM premix directly on the blood clot, and then after the initial setting, by replacing the you know wet cotton pellet, and then you can restore the cavity using the composite resin or something like that. Okay.
Sorry, the question asked by Dr. Ping totally 3 questions. Number 1 question, how about alumina-free bioceramic products such as TotalFill BC? Although alumina produces a negligible response from the surrounding tissue, effectively having no biological or physiological effect. Is that mean an alumina-free BC product better than a conventional BC sealer?
Okay. Calcium aluminate, alumina is usually included in the bioceramics for enhancing the setting time or the initial mechanical properties, something like that. But in terms of the sealer, I don't know actually. But for the MTA, the powder type MTA, the calcium aluminate should be included because it is required, necessary. But for the sealer, I don't know. But as you know, recently there are calcium aluminate based root canal sealer is produced by some company. So, but we need to evaluate that kind of cement. But I have no idea about that at this moment. I'm sorry. And second question.
Second question, moisture is necessary for setting. When use a bioceramic sealer, it is not necessary to completely dry the canal with the paper points. I was wondering about, will the CWCT obturation method affect the properties of the BC sealer? BC means a bioceramic sealer.
Yeah, you mean the moisture dry with a paper point?
Yeah, moisture is necessary for setting. When using a bioceramic sealer, it is not necessary to completely dry the canal with the paper points. He was wondering about, will the CWCT obturation method affect the properties of the BC sealer?
Oh, okay. There's no enough evidence that the heat, the effect of the heat on the bioceramic sealer at this moment. So what I'm saying, the heat change the sealer chemically, but there's no adverse effect in terms of the clinical result. So I think there's no problem when you use apply the heat into the bioceramic.
The third question is that if a bioceramic sealer is biocompatible, would the extruded sealer compromise the apical tissue healing process?
Actually, there are not so many clinical trials until now where the bioceramic sealer. So there's not enough amount of the literatures in terms of the clinical point of view. But I found a recent paper from South Korea, that bioceramic sealer is more favorable in terms of the clinical result compared to resin-based sealer, but it's not obvious. But what I'm saying is that what the reason why I suggest bioceramic sealer is the clinical result. You can use the resin-based sealer, any sealer you can use, but it is convenient and the handling property is good. You can use the single count technique or something. The moisture is not susceptible, or that kind of reasons. I suggest to use the bioceramic, but clinical result, I'm not sure yet. We need more time and more research. Oh, you haven't. Excuse me. Oh, it's actually Korea is a 11:10, so too late. So how many questions remained?
Only 2 questions remain.
Oh, okay. Time difference.
Yeah. The second to last question is, how many success rate of partial and full pulpotomy in use of bioceramic MDA compared with the root canal treatment in long-term installation of cases?
Oh, actually, I have no idea about it because but actually, if you use the rubber dam and aseptic technique, pulpotomy has a very high success rate, I think. But its case selection is very important, you know. But if the pulp is healthy, most of the case is successful. But if the patient have the pain or the symptoms such as irreversible pulpitis, something like that, success rate will be decreased. So case selection is very important. If the pulp tissue is exposed by accidentally, just mechanical exposure, success rate is very good. But yeah, it depends on the condition of the dental pulp. And the root canal treatment, yeah, it depends on the case. If the retreatment, our success rate decreased a lot. I cannot say anything about that.
The last question is, can we use the MTA in the cases of open apex cases?
Open apex is a very nice indication for the bioceramic material because to manage the open apex, traditionally we place the calcium hydroxide paste for a long time, about the 6 months or 1 year to make the apical barrier. We call that apexification, but it is time consuming and the patient should wait a long time, so it's very tricky now. So nowadays, because MTA is very biocompatible, so even though it is extruded a little bit beyond the apex a little bit more, it is okay because it's biocompatible. So we place the apical plug with the MTA and then fill the root canal with the gallopage sealer up to the apical plug. So we call this procedure as a one visit apexification. With MTA, it's possible, but other materials, I don't know. So MTA is very good for the apexification with the immature root apex. Good question.
Dr. Myatanzo has another. He has another question. the very last question.
Sorry, doctor. May I have one more question?
Oh yeah.
I would like to know if it's possible, if it's required to use an agitative method for the filling the lateral canals which means I meant by, if for example, if we have two canals and there's a lateral canal connecting these two, which we usually do is we fill the calcium hydroxide paste and then agitate it using the activator. So just as you mentioned before, the flowability of MTA is this endoceal MTA is quite high. So do we need to use the agitating method, or should we just fill it normally, sir?
Agitating with ultrasonic or something?
With an activator, sir.
Activate whether manually or the ultrasonically.
Ultrasonic activator, sir. Yes.
Actually, the first guy who developed the ultrasonic activated agitation is me. I published my paper in Journal of Endodontics 5 years ago. Yeah, it works. It works, but clinically speaking, yeah, it's okay, but it is not necessary. I don't activate anymore because it's very time consuming and very tricky, technically. So even though you use the bioceramic without agitation, I don't think there's a problem. There's no problem.
Thank you, doctor. Thank you for the time.
My pleasure. My pleasure. I'm very happy to see that the dentists here in Myanmar are interested in ultrasonic agitation. It's good.
So thank you very much, Professor, for the precious time you give for us, even though very tight schedule. I hope we can do more webinar like this in the future more. Thank you
Yeah.
very much. Thank you for dropping by, and thank you.
Oh, thank you for inviting me. And it was my great pleasure to be with you in Myanmar. And so I hope we can meet again online or the in-person, offline. Yeah, I hope so. Yeah, thank you.
Thank you for your
Thank
time.
you.
Doc.
Thank you. Can I leave?
Yes,
Yes,
thank
sir.
you.
Good night. Have a great
Okay.
night.
Good night.
Good night, you too. Bye.
webinar လေးကိုတက်ပြီးတဲ့ဆရာတို့ဆရာမတို့လည်းကျေးဇူးတင်ပါတယ်နောက်ဒီလိုမျိုး webinar တွေကျွန်တော်တို့အများကြီးလုပ်သွားဖို့လည်းအစီအစဉ်တွေရှိပါတယ်ဆက်ပြီးတော့စောင့်မျှော်ပေးကြပါအောင်ကျေးဇူးတင်ပါတယ်ဆရာတို့ဆရာမတို့
Okay ပါ okay ပါ good night
Good night ပါဆရာ